I'm grateful to have Dr. David Fawcett here again, joining on the webinar. And Dr. David, what do you have for us today?
Thanks, Tammy. Always great to be here. I wanted to talk a little bit about a slice from Sex Under the Influence, Sexualized Drug Use, that looks at gender differences between men and women and how that
Yeah.
presents. I think it's something we don't talk a lot about. We talk about the different drugs and patterns of that, but there are very distinct patterns between men and women. I want to just start out by defining sexualized drug use, or also sometimes known in slang as chemsex. What that is when we combine two addictive behaviors, or two or more, but one involving substances and the other involving sexual behavior. And so it can be alcohol and porn, it can be cannabis and porn, it can be methamphetamine and sexual acting out, or any combination of those things. And it's not just using the two simultaneously. So it's not enough to say, well, I'm going to have a drink of beer or a glass of wine before being intimate with my partner. It's more about this whole interaction. First of all, the quantity is much higher, but it's really where the two uses of those addictive behaviors, the drugs and the behaviors, kind of fuse into one. And actually, when it hits and is fully developed, we've had a lot of clients that really say they combine cannabis and porn. If they decide to give up cannabis, they find that porn no longer interests them, or vice versa, right? So the two become fused in a way that's very difficult to treat. And we've talked here before about how a lot of substance abuse treatment programs don't recognize the sex and porn behaviors, and people just continue to relapse because all those are all tied up into one big knot. But within that, I want to talk about differences in sexualized drug use between men and women. And there are different patterns. Men, the number one drug of choice is alcohol. That's probably not too surprising. It's not the drug of choice for women. We'll get there in a minute. But alcohol, when you think about it, when you look at it, the science of it is a really terrible drug for sex because it kind of makes everything messy. People have a hard time getting erection. People can't orgasm. It actually decreases testosterone over time. So it's really not a good drug for sex. One or two glasses of alcohol actually has an arousing effect. That's the disinhibiting thing. That's really what people are using alcohol more anyway for, is that disinhibition to get over being shy or being uncertain about themselves or their bodies or whatever kind of hangups they might have that might interfere with their ability to enjoy sex. So alcohol is a great way to start that. However, if you go past two drinks, the benefits rapidly go downhill. So I mentioned alcohol in this context because some people don't even think of it as a drug. And I've always said if alcohol were introduced today, it would never be approved because it's a really terrible, toxic drug that causes terrible withdrawal and overdose and death in many cases. We have a lot of deaths this year in any year because of liver and cirrhosis and things like that. Following alcohol for men still is stimulants. This is where we get the amphetamines, cocaine, crack cocaine. Methamphetamine is the drug I've studied most over my career, and that's the one that has the most powerful impact, about 13 times the amount of dopamine released from just walking around. So it's a huge amount. An orgasm, by the way, orgasm without drugs is twice the amount. This is 13. Yeah. So it's a very addictive drug, very co-occurs often with these kind of sexual behaviors and sexual acting out. And then the third most common drug associated with men and sexualized drug use is erectile dysfunction drugs, believe it or not, because these behaviors, whether it's alcohol or the amphetamines, quickly cause dysfunction, sexual dysfunction, erectile dysfunction, and it's an ongoing problem. So weirdly, those are the kind of the three big ones for men and sexualized drug use. The picture changes really rapidly when you look over at women. And first of all, I want to say that there's a real lack of research across the board on women and health and women and drugs specifically. Almost all the drugs are studied on men or college kids or very small samples. And therefore they're kind of approved for men, but they're generalizable to women. But we know that women process many drugs differently, they react differently, and so on. And this really plays out in sexualized drug use and where we see that. So they respond differently in many populations. The number one drug for women and sexualized drug use is cannabis. And Tammy, you and I often talk about how cannabis is becoming normalized and people don't see it as a dangerous thing anymore because it is legal and there's medical marijuana and everybody's grandmothers and grandfathers are popping gummies at night to sleep. And it's just like become across the board. However, for women that really use it differently with sex, it's extremely popular. A couple different reasons for this. Women can use less of it and get more of an effect. It has a different effect than with men. It impairs spatial memory more, which it just affects kind of different how uh, people perceive the world around them. It reacts differently in women than in men, but perhaps most important, men just simply get a greater high from cannabis than women, despite the fact that women still use cannabis more. The high that men experience, and this is hormonal, and it's just based on body chemistry. Men tend to have a greater high from cannabis. Um, when it comes to amphetamines, and this is maybe one reason why women don't use them as much, women are much more susceptible to the extreme highs of amphetamines, to the point where it kind of blasts through the this is fun phase into like this is terrifying, right? Women often react more strongly with that. And that has to do, we think, and again, research is still has big gaps in it, but we think that because of the increased amount of androgens, hormones in women, they react differently to amphetamines. Another kind of reason why we need to test all these drugs on different things. Women, for when it comes to MDMA, ecstasy, which is another drug that's popular, women have more hallucinatory effects than men from ecstasy. Again, pushing them into kind of this is not so fun. This is more kind of uncomfortable and scary. And so they kind of withdraw more from MDMA. And then overall, when we look at mood altering drugs, women tend to have more depressive effects after it's all over. So women are more susceptible to depression following a lot of these drugs. And again, it makes it less likely that they're going to repeat the use of those drugs. So cannabis and not amphetamines is the most common. Amphetamines and alcohol are the most common for men, and just very different. With alcohol, now alcohol is another one. Of course, women drink alcohol too to disinhibit. Um, Alcohol is also processed different than with men. Alcohol remains in the bloodstream longer for women. And this has to do with alcohol is metabolized, turning basically into a liquid. And it goes through into the muscle tissue quickly. It dissipates in the muscle tissue more easily. Women have more fat cells in their body overall, and that slows down the metabolism of alcohol. So the effects of alcohol can actually be greater for women with lesser amounts ingested. So all these are kind of technical, but my point here is that it's not just enough to sort of look at whether everybody uses methamphetamines and amphetamines, because that's really not the drug of choice for women in sexual and sexualized drug use. The one exception to that, just as a footnote, is that women who tend to be sex workers tend to use methamphetamines more, I think, because the clients ask for them. And we've had many clients through Seek Integrity men who come in, and when they get involved with sexualized drug use and get involved with, these are straight guys, with methamphetamine, it often comes through sex workers. There's basically their drug supplier. So, but that's not generally true for women. It's generally more the cannabis is the attractive drug. So all this to say that we really need to look at the individual cases. We need to look at gender and recognize that and the patterns of use. It's just not enough to kind of make easy generalizations across the board. It just doesn't work. So that's just a little snippet of it.
Yeah, no, it's really fascinating. And I was surprised that and alcohol, I was thinking, well, it's so easy to get. I mean, like that is, you don't need a prescription. You can just go to, you go to the grocery store, so it's really easy to get. So that does not surprise me, but it kind of surprises me that it isn't the same for women, because same thing, women, like there's lots of t-shirts that say, it's whining time, and it's, with a glass of wine. I mean, so my perception would have been different. I'm not surprised our bodies process things differently, but it is interesting, how much different it is, and that the side effects or the results are so different. Like, that it would be like having a terrifying experience where a male could be having just like, this is the greatest thing ever, those kind of I mean, that's so different.
Yeah, very much so. And by the way, this is true for pharmaceutical drugs as well, right? The same different responses that we don't really know enough about. But here we're just talking about so-called recreational drugs, and that affect the differences still stand across the board for sure.
So, and this is probably a lot, why, why are the studies, so male focused and not looking, I mean, if there's known differences, why would, like you said, even with pharmaceuticals, why would we not be taking that into consideration?
I think it's just a general bias that exists in medicine and research across the board, just kind of assuming it's kind of one size fits all. And most science is, this is changing now, but most science I think is male based and male oriented, and it's just people didn't think of it. It's a strange thing. I think we're catching up now. We realize there's huge gaps in the literature. Even in, I'm a sex therapist as well, and even in sex therapy research, it's always been male focused until just recently. Just it was mostly men, and they're interested in things that were self-serving in a way, right? Women's sexuality didn't really come into focus till much later. I always laugh. One of the techniques we use with our clients to kind of reintegrate some kind of healthy sexuality is a technique Masters and Johnson created called sensate focus, which is a mutual kind of touch exercise that helps rebuild intimacy with couples. But that was created as a way to treat male erectile dysfunction. It had nothing to do with
Oh,
healing both the men and women. It was just strictly to do something for the men, and the partner just was a tool in the process. So it's just there's this bias that exists and has existed for a long time.
I hear that. And when now, and you were talking about like the difference, body fat and things. I would anticipate the difference in our hormone makeup, could also be playing a factor. Is that, do you think, accurate to the best of
Totally.
our knowledge?
Yeah, and there's some research with the androgens and all the other hormones for sure. And I think it has, and again, because of these gaps, we don't really know to the extent that's true, but I'm sure it is true, from what little we know, for sure.
Well, there's a research project for you to take on. It would be really,
Right.
really good to know that. So questions from the group, we would welcome, questions about, any of these things. And, the question, uh, well, okay, so you talked about, alcohol wouldn't be permitted today. And I go, yeah, but cannabis it was, and we should have known better. That there's a little bit of that for me. It's like, we should have known. We should be going like, we wouldn't, I don't think, approve alcohol, as unilaterally as we have. And yes, we have age groups and things like that, and how many underage, people drink. But with cannabis, it's like, we didn't do the long-term research. We didn't look at all of these possible negative, effects of what cannabis is doing. And we just went, oh yeah, we're going to legalize it. And the legalization and the medical marijuana, and you can get a medical marijuana card. You have a cut on your finger, you can get one, there isn't stringent, looking at this, or even, is this person well suited to using this as, supplemental. We've talked before about the psychoses and like all of the really negative effects of it. And we did that even knowing, there's lots of really negative effects of alcohol. And we've talked before too about alcohol, like the alcohol of our forefathers, the founding members of the United States, they were drinking beer while they were writing the Declaration of Independence, but it was mostly water. It wasn't what we drink now. Don't, but yeah, but it isn't what is served now, with the higher alcohol content. So all of these things have progressed. It's in our world, it's more is better.
It's so true. I think with cannabis, it's been kind of a drip, 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 right? Little mini steps, certain states adopting it, and then the medical piece coming along, and really behind the research. Now we're getting much more research lately that talks about the really damaging effect of cannabis on the developing brain. So adolescents, much less on adults. You can still get certainly addicted and it can do harm, but it really does harm on the developing brain up to 25 years of age. So I think that's one area there it's really strong. And the other thing is, as you mentioned, is the cannabis today is, not nothing compared to like the basically sticks and twigs that I smoked in college, that
Hmm.
it's a very different thing. And the number two drug around that creates psychosis, psychiatric, like that mimics the psychosis you see with schizophrenia or bipolar illness or whatever else, is cannabis. It's methamphetamine and cannabis. And both of them are implicated in inducing actual schizophrenia and other kinds of thought disorders that in certain people. And they've actually tested, are these people that would kind of develop it anyway, that were vulnerable, and they've determined that it's not necessarily. It's something about cannabis in certain people. They don't know what the vulnerability factors are, but it can induce that. And I think I've mentioned here before, a friend of mine who works in an adolescent and young adult treatment center for substances, it's all cannabis, and about half of them are psychotic. So it's a
Oh,
really
wow.
dangerous drug that we totally underestimate. But cannabis, at least on the street today, is nothing like it was. Same with methamphetamine, by the way. When the cartels took over manufacturing it, it was the most before that the most purity we'd get was about 90% pure, by definition. Today it's up into 97, 98% pure, almost pharmaceutical grade, right? So all the drugs available to us have just gotten so much stronger and so much more devastating. And I think we haven't caught up with our cultural kind of attitudes about them. They're
Yeah, well,
dangerous.
and then as a parent and grandparent, I mean, it's terrifying to think of, the level of general acceptance of like, oh, it's only cannabis, it's only pot, it's only whatever,
Right.
and the minimization. And, you know, I I had recent opportunity to visit a college campus because our granddaughter is looking to go to college. And I was thinking, I wonder how many young people end up not staying in college because they start getting into easy access of this, when they hit, and they're still in that under 25 age range, which you're talking about, and, I don't know. Again, that would be another research, topic, that would be fascinating. So, okay. Could my husband's nightly use of cannabis be a contributing factor to his lack of sobriety from porn? Oh, goodness. We're going to talk about co-occurring in a moment. If so, could you explain this relationship? He is usually high while consuming porn, yet he tries to abstain from porn. His cannabis use goes up. This is
There you go.
exactly your question. Yes.
E- Exactly. Thank you for
Yeah.
the question and the
Yes,
observation.
please.
And
Yeah.
yes, I mean, they're absolutely related. Cannabis, again, as we've just been saying, is as this kind of, oh, it's natural, it's a plant, right? And we kind of minimize the effects of it. It's a very strong head high and body high. And it is a perfect match for addictive behavior, especially porn, because porn, you go off into your head, you're off in that fantasy and that bubble, as we call it. And cannabis directly contributes to that and kind of encases the whole experience in this physiological high due to the substance. And so the two quickly bond. It's a perfect one of the most common examples of sexualized drug use, where the two become dependent on each other, where and then one is not fun without the other. And so they gradually over time reinforce that bond, and it becomes one that's very escalating. Now, if you're trying to quit one without the other, it's not going to work. And this is my gripe. Tammy and I have talked about this with treatment centers in this country, drug abuse treatment centers that treat, and we've had clients seeking charity, many of them who get sober in a drug program and keep relapsing or can't get sober because they have sex and porn addiction issues that are totally unaddressed, and they're part of it. It's not just a separate behavior. They're all woven in with triggers and cues and reinforcing each other. I'll never forget, we had a client at Seek Integrity who was a porn user and got in trouble with underage porn, and the FBI took his computers, and so he didn't have a computer. He was terrified of going on porn, but he'd also been only using methamphetamine with his porn and a whole stash of meth. And he said, well, I might as well use the meth, even though I can't look at porn. He couldn't get high. It was no fun. They were totally bonded together. And the same true as with cannabis and porn. It is the two bond together. So yes, I think both of those addictive substances and behaviors must be addressed. concurrently, and they're absolutely going to reinforce each other. There's going to be a relationship there. So, you know, the phrase I use sometimes is whack-a-mole. When we are treating issues, addictive issues, right? If so, we treat the cocaine addiction or the ecstasy addiction or the porn addiction, but very often, if we don't treat what's going on around it or the other addictive behaviors that are kind of encasing this whole thing, we're just going to switch addictions, right? So I've seen many people get sober from substances and switch over to porn or gambling or food. It's very, very common. So I think we have to really recognize the bigger picture here. It's not just the cannabis, it's not just the porn, it's the whole thing. It's the bigger picture of all these other behaviors that are wrapped up with it.
I still agree. You know, in our residential treatment program, we treat these issues holistically. And like you, I've seen lots of people have gone to substance programs, and their whole thing is, well, if you just don't do the substances, you're sober. And we're going, no, no, no. It really, we have to look at these things holistically. We have had guys that have come who have had gaming issues, gambling issues, food issues, you know, whatever it is. And if we're not looking at those holistically and going, what are we looking to do? Escape, numb out, you know,
Exactly.
compartmentalize. We're looking to not be integrated into life. And we both are 12-step program people. So we talk about being happy, joyous, and free. We cannot be happy, joyous, and free if we're using something external to try to make ourselves okay, which is exactly what we're doing. It isn't because
So,
alcohol tastes so great. It isn't because, you know, I mean, porn and sex aren't about the porn and sex. They're about escaping, you know, and the images, and you know, and Dr. David is he had on a previous webinar a chart, and it showed how the use of, you know, sex and methamphetamines, you know, amp up, like you can't, that is not a naturally occurring high. So it makes it extra difficult to, you know, to unpack all of that. And as long as we're hanging on to one or the other, we've had guys that have been sober, you know, basically abstinent from alcohol and drugs, you know, for years, and they have full out, you know, sex and porn addiction. And so they've never really been happy, joyous, and free because they're using something else. And so the invitation with recovery is that we look at all of the problematic compulsive behaviors, but we get the support that we need to address those underlying issues, so we don't have to just keep doing the whack-a-mole that Dr. David is talking about. So it's such a good way to live, and it's scary as heck, you know, for, you know, any of us that are going, but we don't know how to do life, you know. I get it. We get it. And we can learn, you know, and that's the gift of recovery. So we have a little treatment program called Seeking Integrity Los Angeles for guys like your husband, you know, that are struggling with the co-occurring, you know, to spend 14, 21, or 28 days and get a solid plan of recovery. It's hard to do this on your own, you know. In fact, you can't do it on your own. You can do it with 12 step and a qualified therapist. And, you know, if you create a plan, you know, 90 meetings in 90 days is a good start, you know, but you can create a plan, and it's going to take more time, but, you know, getting that solid foundation in such a short amount of time, you know, can really be a gift to each and both of you, if you choose it. And you can email me, tami@seekingintegrity.com, if you'd like information. Okay. I'm an alcoholic, sober for years, and I started drinking too much primarily because my SA husband fed it to me so I would have sex with him. Oh my gosh. Of course I drink due to my own issues. My question is that he drinks a couple of drinks of rye and coke per night. Will this affect his recovery? He has been acting out for 12 years, and as far as I know, still is. Recently started seeing a counselor. He is also an offender. I've got a lot I'm thinking. Please share.
yeah, well, it's not about the quantity. First of all, I think that's a mistake people often make, right? Um, the way I try to approach this is looking at like an individual's entire addictive ritual, like the whole thing from beginning, the initial triggers through the preoccupation, through the acting out, and then the remorse at the end. But very often, we've had many sex addicts of Seeking Integrity and many in my practice who don't drink or smoke or do a lot, but they drink one or two drinks at the beginning, and that sets off everything else. right? So that can disinhibit enough, that kind of sets the mood. It's the gateway that opens the door to the other addictive behaviors. And I think so. I think they're very much connected. And it's not so much about getting, sloppy drunk and into a blackout. It's. I remember I mentioned one or two drinks is the sort of peak alcohol benefit, if you will, in this term, from of getting disinhibited, of getting a little loose, of getting a little in the mood, and then your other addiction or other addictions can take over. So I think, yeah, that those two go together very much so. The fact that he would press alcohol on you to do that is consistent with kind of offender behavior. It's offending behavior at a kind of a lower level, but it's using you for to get what he wants, and obviously that's harmful for you in the long run to ingest alcohol like that. It no doubt has an effect, right, of disinhibiting and all that, but it's really not a healthy way to do it or have interactions with each other. And it's certainly not a way to build intimacy and all the other elements of connection that we strive for, right? All these addictive behaviors and drugs kind of put all that, they numb it out to the extent where that's non-existent. It's other kind of behaviors at work. So yeah, I think there's a big problem there. And I think if he needs and wants to get totally sober from sexual acting out, he's going to have to look at the alcohol as well. The two are, and from what little I know, based on the question, I think it certainly sounds like it's totally integrated into his ritual. And by the way, I mean, anybody that has one or two drinks every night, I think is worth looking at just by that itself, right? I know that's in a lot of cultures around the world, they do that, but I still think in many ways I would have that as potentially alcoholic behavior for sure.
Yeah, it's been interesting in the last few years. There has been sober October and dry January and stuff like that. And I think that there's a number of people who are finding that giving up, stepping away from drinking, has a lot of positive effects, for them. So I think it's an opportunity to look at all of these things. So you said he's seeing a counselor. So normally we recommend certified sex addiction therapists. That said, sex offenders are, not all CSATs are trained to work with sex offenders. So I hope he's seeing a qualified professional that is trained to work with sex offenders. Second part of that is, often there is an overlap. I like math, so I talk about the Venn diagram where there's the addiction and there's the offender, and some are in that cross section that can be treated well with addiction recovery tools. But yeah, I mean, and for anybody who goes, no, I need my rye and coke, the more we hang on to something, the more we should be questioning it, do I really need this? That's what we as addicts do, is we're hanging on, and I want to honor you with your recovery. Yeah, like it's hard, to get in recovery and to be, to live the examined life, but it is so worth it. So regardless of what he's doing or not doing, I just want to encourage you to make sure, we've got nothing if we don't hold on to our recovery. So prioritize your recovery. What he's going to do or not do is going to be up to him, but what do you need to do to make sure that you are taking care of you and prioritizing your healing for yourself?
And in that vein too, I hope
Mhm.
the person writing the question is also having a therapist or counselor for
Oh,
support.
good point. Yes. Yeah.
Because there's sometimes we just need help setting boundaries or getting the insight and getting support.
Hmm.
And so that's out there. So I hope,
Yeah.
hope that's the case.
Yeah. And I've been doing this a while. I have a pretty nice chip, and I still go to my 12-step meetings. I still have a therapist. I don't, go weekly, but I go when I need to, get grounded or touch base on things. So if stuff is, coming up on my life, it is so imperative to me, that I preserve my recovery, because nothing good will happen to me or anybody I care about, if I go back out there. And I want to be, as close to the serenity beam as I possibly can be. Life is life, but how I choose to show up is the only thing I've got any control over. So. Okay, the next question, Dr. David, and we'll take more questions. We'd love them. Does taking testosterone or other products that increase blood flow help with ED caused increased preoccupation with all day sexual thoughts and actions, otherwise detrimental to sobriety? Another great question.
Yeah, and testosterone can be abused because it does increase that sort of sense of sexual drive and sexual arousal to an extent. Uh, Again, we've had clients come in who abuse testosterone for the effect it had, the psychological effect it had in terms of their sexual feelings. So yes, I mean, clearly it can be done, and too much testosterone has all kinds of other complications too, right? That has to be carefully monitored by a doctor because it can cause, for example, your hemoglobin, your red cell count to get too thick, and sometimes people on like bodybuilders have to have blood draws to remove blood because their red blood
Oh,
cells
wow.
are, and it can cause really medical complications. There are also the other unattractive for guys side effect of testosterone is that, like anything we get in excess exogenously or from outside ourselves, it shuts off our own internal creation of it. So if I'm taking a lot of testosterone, my body says, well, I don't need to make this anymore, and it
Oh,
stops making
wow.
it. And so guys on a lot of testosterone have to either cycle off periodically or just accept the fact their body's going to stop making it, and which all kinds of other complications, right? So yeah, there's definitely something to be used with the doctor's, approval. But in short, the answer to your question, yes, testosterone can really affect somebody's attitude about sex and their sense of arousal, and it can be definitely abused because it's a mood changing drug in that sense.
So if your body stops making it, I heard you say cycle off it. If you don't cycle off it, does your body repair the ability to make it at some point, or is that like a lost thing?
It depends. There are drugs that can sort of kickstart your own body's production again, which a lot of people do. Now, if somebody's on, maintenance testosterone prescribed by your doctor, theoretically that is making up for what your body isn't producing, right? So you don't have the effect of where your body stops. So I don't want to scare people who are on medically supervised testosterone replacement therapy, you know, but guys that are kind of doing it recreationally are going to cause big problems for themselves. And we see this all the time. Again, a lot of younger guys who have no need for testosterone are using it in great numbers. There's all kinds of clinics now you can go and like a lot of drugs, you call up and speak to some doctor online who gives you a prescription and you get it by mail, and there's nobody really supervising. And testosterone requires lab work and to really carefully monitor because it can kind of get out of balance really quickly.
Yeah, thank you for pointing that out too. I see the ads for like, yeah, call us up and and we'll send you a prescription by mail. And I'm thinking, who's monitoring this? And with some of these things, not all, but some of these things, there's a negative interaction with other drugs. So your doctor will not know that you're doing this other thing over here. So there's no one, like you said, monitoring or paying attention to the interaction. That can be potentially pretty devastating. Sometimes I
Absolutely.
would think even, high risk, fatal, like with the testosterone,
Mhm.
I'm like, well, if my blood is too thick, I'm thinking I must be more likely to, have a stroke or something too. So yeah,
There are cardiac risks for sure. Yeah.
yeah. Other questions? We would welcome some questions. So going back to the differences in gender, um, do you see a difference in the age that things start, for genders? Like, do you see men or women, girls or boys, I guess, starting use of substances at different ages?
Yeah. A lot of it depends on personal history, right? We know that trauma, for example, or traumatic experiences, adverse childhood experiences can really impact how soon a kid, male or female, gets involved with sexual behavior or addiction behavior. So when we see people with a family history of addiction, we see it often very early onset of these drugs. There does tend to be a sequence, so people, men and women, tend to like start their drug use typically with alcohol and cannabis. Those are the two, just because I think they're most commonly
Mhm.
available for people. And then we get into things like ecstasy. Unfortunately, a lot of people now are abusing the ADHD medications, which are
Yes.
really pretty strong amphetamines. It's a real problem among young adults, male and female. Things like Ritalin or Adderall or Vyvanse that are overused, overutilized, I think overprescribed and abused by almost everybody, even people that aren't addicts. Well, I've heard people talk about, well, they have a big exam coming up or things like that, and they just take more. So that's a real problem. Um, but then these really stronger drugs like methamphetamine and some of the opioids tend to come on a little bit later. They're not the first drugs typically that people use, although everything's up for grabs these days. When I started practicing almost 30 years ago, the meth was like the last drug on board, right? And that's typically, I guess, we're seeing guys in their 30s, and they would always start smoking, and then over time graduate to injecting. And that was like the end stage, we called it. Now I'm seeing younger guys start their first experience with meth is having somebody inject them. Uh, so it's like
Wow.
everything's on its head right now. All the patterns are upside down. And I've asked people why, and it's the thrill, right? It's the risk involved. And we know that a lot of the amphetamine users tend to be what psychologists call sensation seekers. These are people whose personality is, the danger, rock climbing and parachuting and driving your motorcycle too fast without a helmet and dangerous stuff, right? Speed and so it makes sense that they would kind of be thrilled at the risk of somebody like what's going to happen. Let's see, right? And it's a very as a therapist, I'd like to work with that person on their own sense of self and self-worth and all that. But so that's a long way of answering your question. I think it's a mixed bag. I think the kind of drugs that people use are generally sequenced where the more common ones happen earlier. But depending on individual stories, I've seen people get involved with opioids or amphetamines much earlier than that. So depending on circumstance. With gender differences, I think again it's almost I think men tend to get involved in different substances sooner than women, although you can find somebody who proves the opposite in any case, right? Yeah.
Yeah, it's more generalizations. So, when you're talking about these, the thrill seekers and things like that. So, um, like I don't think most people go, "Oh, when they inject me, I could die," So, like I don't even know how you combat those messages of, like how do you interrupt something like that and go, "Yes, you could die. The probability that you will is greater, and we want you to be here on this planet." Like I don't even know how if there's such a disconnect, because I don't think I have my dead artist list of music, and I go, like the ones that got in trouble with substances, and I go, do you would had you known that your life and your career would be over in a second, would you have chosen that path? Of course, there's no answer to that, but I like, how do you even, as a therapist, how do you even intervene on that?
It's really hard, obviously. And I think what I would try to do is look at the impulse or the trigger when that happens, when those things come up, what's really going on. I think, and that those sensation seekers in that extreme are kind of the extreme end of it, but with almost every uh, sexualized drug user, there's some version of that. And it's seeking excitement and thrills. And we know that sexualized drug use mimics the body's fight or flight response, right? It's what we call a sympathetic arousal. And so there's certain drugs and behaviors that do that. So amphetamines, for sure, um, pornography, sex addiction, kleptomania, uh, weirdly, but it's all involved in the risk, the thrill. People don't shoplift because they don't have money. They shoplift, they're going to get caught. And I think it's the same kind of thing. If somebody's going to inject me, it's like, wow, there's a risk here. That's the thrill part. But I think some part of their brain, their rational brain, is kind of not realizing, yeah, there's fentanyl out there. They're not doing the rational calculation of the dangerousness of it. I might add, I mentioned the drugs that kind of do the stimulating piece. There's another side of addiction, the numbing side of addiction, that's more like what we'd call the freeze response in trauma, not fight or flight, but freeze. And that's alcohol,
Mm,
food, um,
mhm.
binge watching TV. These are all numbing kind of behaviors that kind of have a very different response in the body. And by the way, any sexualized drug user is going to combine those. Any sex addict too, because what they'll do is do the high risk stuff, the sensation seeking stuff in the beginning, and they act out. Then when that remorse phase sets in at the end of the addictive cycle, they don't want to intensify that. They want to numb that. And so very
Mhm.
often a sex or porn addict, once they've acted out, will go toward food or binge watching TV or some other kind of numbing behavior. So we combine it, we mix and match. But I think basically overall, sexualized drug users tend to be on that stimulation side, at least initially.
Well, and you point out exactly what we talk about with holistic help, with our program. We're looking at all of these things that you're using compulsively or to numb out and escape, like
Exactly.
everybody needs a mental health break, and but it's like, is it a healthy break, or is it like I'm doing this intentionally to numb out and escape because I can't deal with life? And so, yeah, looking at the entire cycle of it. So we've got some more questions. I have experienced a repeated cycle of infidelity. My partner says his addiction doesn't let him break away from his affair partner. I have set clear boundaries, but I live with a terrible fear. He wants to continue our relationship and repair the damage. What do you advise? Wait, his his addiction doesn't let him break away from his affair partner. And you set clear boundaries. Oh goodness. Okay. Thoughts?
Um, well, yeah, I mean, his addiction is at work there. I guess the solution would be to address the addiction and the affair partner, cut that person loose. But I think, yeah, when we're in this active addiction, um, I think the our sense of possibilities kind of narrows, right? We live in this closed universe. So, well, I have to do this because otherwise that things aren't going to be satisfactory. They're not going to work out the way I need them to work out. I think, yeah, this is a perfect case of where he needs, I think, to get in treatment and get some support for addressing the addiction and cutting loose the affair partner. I think I hope you're also getting support for your boundary setting and for your follow through. If he can't do that, I think in a way we and I don't know if this has happened in your case, but when we don't um, follow through on our boundaries, it just kind of allows the behavior to keep going. So that's why I'm always encouraging people, if they're going to create boundaries, really think about them very carefully and be ready to follow through, to pull the trigger if you need to, because that may be necessary. But yeah, I mean, that statement kind of is a perfect example of an addict rationalizing um, why they need to do something and how they're kind of trapped. They're victims in this thing where they just can't change, and that's just not true, of course.
Yeah. And in his active addiction, I can see that, it's like, if it was alcohol, I can't give up alcohol. Well, in your active addiction, you can't until you have the tools to do things differently. We have an expert residential treatment program that would help him 14, 21, or 28-day length of stay. I suspect he's not a 14-day client, just from what you shared. And I want to tag on to I have set clear boundaries. A boundary is not punishment or control. A boundary is, and Debbie McCrae has done a beautiful job with webinars on ours, but it's like I'm stating what my need is for safety. And if my safety is you can't build trust when there's this other person in the relationship unless you agreed to it prior to that, but you wouldn't be here writing this if that was the case. So he cannot build trust. Of course he wants to continue your relationship. The old saying, I want my cake and eat it too. Well, he wants you and he wants the affair partner. He doesn't have to decide then. He gets both of you. So how dysregulating for you to be in this situation where, well, I love my partner, I want to be in this relationship, but he's still over here doing things that are problematic, to the relationship. So a boundary would be, in order to build trust, I do need you to get the help that you need in order to stop seeing the affair partner and to be on a different path. If you are unable to do that, then I'm going to be doing what I need to do. I'm going to sleep in another room. I'm going to, sleep in a different, space, whatever it is. But there's a stated consequence of if you are unable to meet this. And so healthy boundaries are for my physical safety, financial safety, emotional safety, spiritual safety. It's what I need. And it's not a list of 150 things that I want. And they aren't boundaries without a consequence. And if you can't enforce it, if you say, if you do that again, if you contact the affair partner again, I'm going to divorce you, and you don't, guess what? The addict knows for sure that there's no meat in it. So there's no teeth in it that I can figure out how to manipulate around there. I threw in our team does support sessions. I often do a support session with partners to kind of talk about boundaries, and we're really specific. If we're doing one 25 or 50 minutes just to talk about what they are, because they're all individual. It's different. Like this is different, of what you need. With substances, if it literally is just substances and it's a rare person that I see that absolutely the only thing that they're acting out with is substances, then yeah, abstinence is sobriety, but still recovery is integrating this into all things. So I'm going to rephrase what I hear is I'm not willing to do the work to stop my problematic behavior, but I still want you. And you have to decide if that's okay with you. I will put one more thing in after I read the next question for Dr. David. But, we had a 4-part series for should I stay or should I go? And it's just good information. It's like whatever you choose is up to you. But Kristen Snowden did a webinar in May, and she had 10 questions to ask and journal about, just to see, kind of see where you're both at is really, good. And then we had a partner, one with Debbie Allen, one partner stayed, one partner left. Then we had someone who does mediation and actually works in the sex addiction arena. And then we had some legal advice. And those 4 webinars, are really helpful just to get kind of a framework and decide, for yourself, where you are on this, spectrum of things. So, and again, we have support for healing, regardless of, what you choose. Some stay in a relationship where there is active addiction, no judgment. But how do you find regulation and take care of you, in that? Okay, my estranged husband thinks because I am prescribed an amphetamine for narcolepsy that I'm addicted to it. During the amphetamine shortage, I had to go many days, weeks without my prescription, and was occasionally a little more irritable due to this tiredness and my sleep schedule a bit off. Would you consider this an addiction and call these withdrawal symptoms? Is there a difference between using a prescribed drug for a serious medical condition and recreationally using the same drug? And it says, for reference, I'm the betrayed partner and my husband is the betrayer, and with many addictions, including porn, sex, alcohol, food, gambling, etc. And it sounds like he's in active addiction. And again, until unless you get the help that you need to stop all of them, you can't be in recovery. But interesting that your husband is pointing out to you when he's got a buffet plate full of addictions on his plate. So, Dr. David?
Yeah, I mean, there are many drugs like amphetamines, like opioids, that are used recreationally, abused recreationally, and are also have necessary benefits medically, right? And this is one for amphetamines with narcolepsy, is one of the validated reasons why you should, a physician should prescribe those drugs. So there's a medically indicated reason for it. Now, even if there's a medically indicated reason, if we take certain drugs, we can become dependent on them, right? So people that take pain meds For chronic pain, they may be physiologically dependent on those drugs, although they're required. They're not using them because they're having a good time. Now, with amphetamines, you don't get physiologically dependent. So there's no withdrawal, for example. There's no dangerous effects of that. We do, however, get somewhat psychologically dependent. Our body starts to expect a certain sensation, and when we don't get it, it complains. And so I'm not surprised at all you'll get irritable, which is one sign of withdrawal, so to speak. We see, often over sex and porn addicts, there's no physiological addiction, but when they come to seeking integrity and they're without their affair partner or their phones or their computers, they get cranky and they get irritable and they're going through a sort of a psychological withdrawal. I suspect that's what happened to you. This is not an addiction, right? An addiction is when we take a mood-changing substance or behavior to kind of self-medicate, mostly an emotional self-medication. That's not the case here. It would be similar, I think, to people who have ADHD who take Vyvanse or Ritalin or Adderall. If they take it correctly, it's a necessary drug that replaces some of those naturally occurring neurochemicals that are in deficit. And so we take them from the outside to bring us back to kind of normal. That's what you're doing to combat the narcolepsy. So it's not the same thing. It's not an addiction. Is there some psychological dependence? Yes, probably, because anytime we use some of these strong drugs, that happens. That doesn't mean you're an addict that uses this because you're having a bad day or you're bored or all the other reasons that addicts cite to use these drugs. So I hope that is helpful. Yeah, in short, there is probably a little bit of a psychological dependence, as happens with these strong drugs. It's a necessary byproduct of your medical condition and the treatment for it.
So the next question, my essay husband is a really nice guy and he is always the first one to help anyone. I think it's interesting, and this is anonymous, I don't know who you are. I think it's interesting that you start with that. He has had sobriety on and off for 2 years, and he's going to groups and seeing a CSAT for 2 years, but always relapses after a few months. He has depression, ADD, and BDP. So is that bipolar? Probably.
I
It's
suspect, yeah.
bipolar or borderline. So, okay. We've been married 15 years and have 3 kids together. I love him. I have compassion for him, care for him, but his addictions, food, phone, cannabis smoking, are killing me. And we are separated for a year. He's still a good father and person, but he is not fighting for me. My question, are some addicts just not able to get better?
In the big book of AA, what, almost 100 years ago now, they there's wrote that some people are constitutionally incapable, right? I have never met one of those people. There are people with like very extremely mentally ill who, can't focus enough on recovery to maybe stop going through cycles. But this your husband or your ex or whatever you call him, it sounds like a perfectly high level functioning person, right? He has emotional life. He cares for you. You care for him. But he sounds very much like an addict. And given everything you say, no, I mean, there's no reason why he can't get better. It's a matter of really recognizing. I think if he tries to piecemeal the recovery, like I'm going to work on my porn, I'm going to work on my sex, but I'm going to ignore the food and the drugs and the cannabis and all that stuff, it's not going to work. Depression is a complicating factor in this case, because moods can pull us in directions and serve as triggers, but there's ways to help people recognize, okay, now I'm getting a trigger. There's things to do about it besides going out and using or acting out. So I think no, he needs to address all the problems, and I think he just needs someone who can help guide him through that process. But this is kind of that addictive self-talk that we do to kind of keep ourselves locked in place. And yeah, I would say with the right therapist and support, he could absolutely go through this. And if and it's painful, I know, when we care about someone and they can't seem to get it, even though it's killing us. But I think it's really his responsibility to do that, and he can. There's no reason not to, from what I know here.
So, I got a few things. First of all, no addict changes until the pain of change is less than the pain of staying the same. and right now he's kind of got things, like you're separated, but he still gets to see the kids and all of those kind of things. And so I wonder what the plan is, and hopefully you're both working with, qualified professionals, but just separating and not having a plan is just separation. And so I'm wondering, what is the plan of, like, what are you looking to see? Is there a hope for reunification? I hear this is killing you. So clearly he's not yet in a space to do that. But was there a plan of, like, this is what I'm looking for you, and I'm going to put the relationship in safe harbor for X amount of time. I usually say 30, 60, no more than 90 days. And then we're going to re-examine that. But, what is it you're looking for? You will always co-parent. You will always co-grandparent. And of course, we all want him to be the healthiest, happiest, in recovery version of himself. But yeah, he has so much going on. It will be difficult. He could go to, 5 12-step meetings a day, based on what you're sharing with this. And so stopping the substances and then addressing all of the other problematic behaviors. Again, our residential treatment program is uniquely qualified because we look at all of these things holistically, address the underlying issues, and have a plan and a support for success after they leave. We have lots of cases that are, I don't want to say worse, but that have higher level of acuity than even what you're sharing here. And they can get sober, and they can be in recovery, and they can be men of integrity. So I would invite you, what do you need for you, to say, hey, like this is crazy making, and I want to get off that train. So what do we need to do to move forward in a different way? Because I'll tell you what, you can be here on the same thing next year, December of next year, and go, now we've been separated for 2 years and we still have 3 kids, and he's a great guy, and he's still acting out, and that would be, and if you're okay with it, again, no judgment, but I hear the pain. I can't handle this anymore. This is awful for me and for your kids. He can't really be the great dad. He can't. He's an addict in active addiction, and if he relapses every few months, that's just his cycle of addiction. There's a webinar Scott Brassert did on that topic. It can be every day or it can be 3 months. Doesn't matter. It's still the cycle of addiction. And if he's using any of those things in between, guess what? Then he's a daily consumer of his addiction. So there is hope. Please hear, like, there is hope, there is healing, there is opportunity. But lots of times, we as addicts get stuck in, like, well, this is where I'm comfortable, and partners are like, I honor that you're going, gosh, he's a great guy. And there's all of this stuff. That's so true. The paradox is true. So, oh, we are beyond out of time. I'm sorry. Thank you, everyone, for being here. Thanks for the great questions. Thank you, Dr. David. It was great to see you as always,
Same
and
here.
we'll
Same here.
see you in 2 months. So
Perfect.
bye,
All right. Thanks.
everyone.
Take care.